We're good to start, sir.
Yeah, good evening, everyone. Myself, Dr. K.C. Misra. I am the head of the critical care unit at Yashoda Hospital, Somajigoda. As a tradition, we are doing this Tuesday webinars since last maybe more than 3 years now, and we try to bring some interesting topic pertaining to our critical care. So similarly, this time, one of the maybe lesser known uh, one of the lesser known subject, non-hepatic hyperammonemia, and that too pertaining to ICU. See, whenever we are thinking about hyperammonemia, we always think about hepatic causes only, let it be acute liver failure or a chronic liver failure cirrhotic patients. These are a different category of patients where hyperammonemia might be there without any hepatic disease per se. To take through the whole discussion, we have two renowned specialists who are going to be our panelists as expert specialist, Dr. Dharmesh Kapoor, who is one of the renowned hepatologists in the country. Maybe sir is having the maximum number of liver transplant exposure in the country. I don't know anyone else might be having similar kind of numbers what Dharmesh sir is having. Second panelist is Dr. Rajashekara Chakravarthi. He is our head of the nephro unit at Yashoda Hospital, Hitec City. He might be joining after some time. For till that time, Dr. Mahesh will be there, who is our consultant nephrologist at Yashoda Hospital, Hitec City. So initially, the flow will be Dr. Kaladhar. He is our HOD critical care at Yashoda Hospital, Malakpet. Will put some light on what basically is non-hepatic hyperammonemia with some few case discussion and all, hopefully. Once the discussion is over, then we'll maybe ask our expert panelists few of the things what are like really important to know when it comes to a hyperammonemia, which is a non-hepatic origin, pertaining to ICU, what to do, when to suspect, and all those things. And in the meantime, whoever is having any doubts or questions, please put all your doubts or questions in the Q&A section so that we can take up those questions whenever we get the relevant time, maybe in between or at the last of the discussion. And I sincerely thank and welcome each and everyone here. Thank you very much, Dharmesh Kapoor sir and Dr. Mahesh and Dr. Chakravarthi sir and Dr. Kaladhar to giving us the time and taking all the pain to presenting and being this part of this. I hope this webinar is going to be wonderful, and I welcome each and every participants today who are going to join now live or maybe afterwards. And we have on Facebook and maybe in our YouTube channels. And over to you, Dr. Kaladhar. You can go ahead and maybe you can continue for your presentation.
Thank you, sir. Thank you, Mr. Sir, for that introduction. So today's topic is non-hepatic hyperammonemia in ICU. This is not a very common entity, but most of the times what your mind knows your IC. So that is the aspect. If you know only, you'll be able to pick up these kind of entities. So the timely identification of this hyperammonemia, which is without hepatic dysfunction, is very important in some subsets of patients. So basically, I will take you through some of the case scenarios. One we dealt with. One is the case report, which I could get it in the internet over in internet. So and we'll discuss a bit of pathophysiology and what are the different studies say, and then finally the RRT role of RRT in hyperammonemia and all, and then probably take the expert panelist opinions later. So with this, we'll go forward. So to begin with, the patient, a 50-year-old female patient, this is one patient where history of epilepsy, well controlled with valproic acid therapy, which she was taking since 10 years. So it's been around 500 mg daily with good seizure control. But when the attendants noticed that the relatives, she was experiencing increased fatigue, confusion, and episodes of drowsiness. So along with that, there was a decline in cognitive function over the past few weeks in terms of difficulty concentrating, forgetfulness, and episodes of disorientation. So when she came, she appeared to be lethargic and had a slowed response to verbal stimuli. Neurological assessment, nothing much of focal neurological deficit, something like a hemiplegia and all were there. So they were not much. So mild dysarthria, impaired coordination, and slight tremors were there. Reflexes were normal. So she was showing the signs of altered mental status with more of fluctuating course, irritability, and occasional agitation. No much of any history of fever, and meningeal signs were like there was no pointing meningeal signs to suggest the meningitis. So the laboratory investigation showed normal liver functions and kidney functions. Arterial blood gas was also normal. So routine blood examination as part of what is might be the reason for our encephalopathy, we did ammonia which showed around 120. So we attributed it as the valproic acid. We know the common cause of non-hepatic hyperammonemia. So we did stop the valproic acid, and then alternative anti-seizure drug, something like levetiracetam was initiated. So slowly the ammonia level came down, and there was a corresponding improvement in the neurological status. So with this background, how valproic acid can cause hyperammonemia? If you look at valproic acid as such, can increase the propionic acid, which actually causes the hyperammonemia, interfering with mitochondrial issues. And other than that, the main mechanism where if there is a carnitine deficiency, which is a cofactor, so it when there is a deficiency, this valproic acid can undergo beta oxidation, and then it will form N-acetyl glutamic acid through intermediaries, something like tryptophan, glycolysis, and amino acid metabolism, and all leading to an acetyl glutamic acid. It causes the carbamyl phosphate synthetase inhibition. So this enzyme is very important, especially pertaining to urea cycle, where actually the ammonia which is there will be converted to urea. So if there is a deficiency of the inhibition of this carbamyl phosphate synthase 1, so the definitely the ammonia will not be converted to urea, and the ammonia genesis and ammonia will increase in the bloodstream. This is how the valproic acid interferes with this, especially in terms of if there is a deficiency of carnitine. So with that one case background, we'll go to another case. So this patient is a 50-year-old woman found unresponsive with the background history of bipolar disorder, COPD, Roux-en-Y, gastric bypass. So she was not having any liver disease. So this is Roux-en-Y done around 1 year back, actually. So when she came, her GCS was very low. So obviously, when GCS is low, we'll generally proceed with airway breathing, and so intubated the patient on admission. So the glucose was fine. There was no hypoglycemia, and creatinine bun and LFT done, slight elevation of AST. Other than that, much problem. So when we checked the ammonia, it was very highly elevated. Most of the times, the ammonia what we get normally is generally less than 45, 50. But here it is elevated too much into 450 micromoles. And there is the initial suspicion of the infection, and hence meningitis to rule out meningitis lumbar puncture was done, which was normal. The albumin was very low, 1.8. There was anemia, which is associated, but imaging showed no cirrhosis. So this is a patient where very severe hyperammonemia occurred without any corresponding hepatic dysfunction. So this patient stayed for 10 days in the hospital. Then encephalopathy never improved. Ammonia levels were fluctuating, but finally she could not be saved. This is one case report. I got it over the internet. So when I looked at the papers, hyperammonemic syndrome after Roux-en-Y gastric bypass. This is one paper by Fenwiz et al., Baylor Institute of Medical Sciences, where they looked at a retrospective review of 20 patients identified through their own clinical practice, where the results they looked at is most of them presented with hyperammonemic encephalopathy after Roux-en-Y gastric bypass surgery. So the mortality here was around 50%. Regarding this paper, I will take you through a bit of what were the findings of them in this observation of these 20 patients. There, the inclusion was there was a noted difference like in weight loss, followed by Roux-en-Y GB surgery, gastric bypass, and all of the patient developed hyperammonemic encephalopathy. And the significant finding is there was no cirrhosis. The patients were taken from different institutes, The results were 20 patients identified. If you look at the women, the female preponderance is very high. 19 patients were there. The age group was between 26 to 69, mean around 45. The onset of encephalopathy, if you look at surprising, which started from 1 month even up to 20 years, 8 years, it is still possible. And the very striking thing is mortality is very high. If they develop hyperammonemia, it will be like around 50% of them, half of them will die. So the ammonia levels varied between 68 to very high levels, like something like 486. So the symptoms ranged from mild confusion to coma. So other results, like they looked at what other possibilities. Something like they were looking at the episodes of hypoglycemia, 10 of them had. So they were looking at whether any nesidioblastosis was there. This is something where obese patient, to meet their demand, there will be a pancreatic hypertrophy happens. So whether this pancreatic hypertrophy after gastric bypass and the patient loses weight, because of which there will be hypersecretion of the insulin causing hypoglycemia, whether this is associated with any the hyperammonemia they looked at, but it did not much of pointing towards it. The baseline insulin levels also they checked in 2 patients and elevated in 1 patient. And hypoalbuminemia was very much was associated with it. And bilirubin and all were fine. Another important finding in this is zinc levels were also very low, which among 11 patients they checked, but among them almost 90%, if you look at 9 patients, have low zinc levels. Even they attempted to look at liver biopsy in these patients to look at any hepatic dysfunction is there. So none of them had cirrhosis. Some some stage 2 fibrosis and mild fibrosis, which was not very much implicating towards having hepatic hyperammonemia. So glutamine levels were a bit high, citrulline levels were low. These are all different findings they noticed. So even they looking at enzyme analysis, in vivo enzyme analysis, which is not very commonly did a test, done test at different centers. Rather, they did at their center, which is equipped with doing ornithine transcarbamylase (OTC) enzyme activity, which was low in 2 patients among 3 that did it. So finally, the OTC enzyme is will be there on X chromosome. So something like the females, if they have homozygosity or heterozygosity, depending upon that, at some time, if with a predisposing factor, it can manifest. Males have, if they inherit the X chromosome, because they have only one X, so it will predominantly lead to very devastating course, leading to lethal outcomes. So this is how they could identify it is a probability of ornithine tricarboxylase enzyme which can be deficient in these patients. So how it, if you look at these patients, like where it is involved, the OTC enzyme, the same thing, same when ammonia plus bicarbonate, they combine and they enter the urea cycle here. So the ornithine transcarbamylase actually converts the ammonia into goes into the cycle, urea cycle, where citrulline, and then later it will be converted into urea and will be excreted. So if this is deficient, there definitely invariably it will lead to increased ammonia genesis and increased hyperammonemia. So this is how most of the findings point towards defect in urea cycle. So the pathophysiology, most of the times there can be a partial X-linked OTC deficiency. So non-genetic factors like zinc deficiency, post-surgical catabolic protein breakdown, and reactive hypoglycemia. Even they looked at interesting find is gut microbiome, which may favor ureolytic strains leading to increased urea and ammonia genesis, and there can be acquired OTC inhibitor. These all lead to the possibility of landing up in hyperammonemia. If you look at in this picture, I want to take a moment and explain. So what are the different organs they handle the urea ammonia as such. So the intestines are the primary source, and the liver is which detoxifies. Skeletal muscle also actually takes up the ammonia and converts it to glutamine. So anywhere the kidneys, which are very important excretory mechanism. So these are all organs which are very important. If you look at the partial deficiency of whatever we discussed, ornithine tricarboxylase and glutamine synthase, these actually can be inhibited by stress like a transplant, as we were discussing about possible lung transplant, calcineurin inhibitors that can be used very commonly in transplant patients. These can actually cause deficiency of this OTC and GS, where urea cycle will be inhibited. And if you look at the ammonia, if there is a dietary protein load and circulating amino acids, it can lead to a lot of ammonia formation. Urea is producing bacteria, something like ureaplasma. This is one interesting finding I could, when I was searching, could go through ureaplasma, ureolyticum, and mycoplasma hominis. Both are the organisms. They are very much involved in producing, lysing this urea and then producing a lot of ammonia. And if there is a sarcopenia, this is very commonly seen in ICU entity. If you look at any patient who comes to ICU and long stay will be there, they will be invariably having a sarcopenia. That is the reason the muscle will not be able to handle the more ammonia. So multiple things will be involved, and probably there is associated kidney dysfunction. The elimination of ammonia will not happen. All this will lead to hyperammonemia, and then it will affect it can cross the blood-brain barrier and it can affect the brain. This is how. So summary of their findings in the study, they said they proposed actually a syndrome they called as GABA syndrome, G small a and HB, which they called as gastric bypass associated hyperammonemia. So in the absence of frank cirrhosis, which can be associated with severe hypoalbuminemia, low zinc levels, possibility high mortality rate with female predominance, that they could draw to these conclusions after their study. So another study I want to point out here, hyperammonemia. This is a interesting entity. We are in the era of doing a lot of lung transplants in India. Also, a lot of lung transplants being happening. Even at Yashoda hospitals, we are doing the regular lung transplants. It was giving intuitive findings here. The systematic review and a mini case series where they looked at in this Amir et al. So between January 2016 to 2018, they were searching between 1995 to up to 2020. Even they included their own cases, hyperammonemia after lung transplantation. The systematic review with 18 studies and 40 individual cases. Here, the mean peak ammonia level they found out to be 769, with a mean after transplant, it is around 2 weeks after that, the patients can develop still possibility. The mortality was very high in these studies. But in their own study, where they were performing the systematic review, they found 180, the peak ammonia as compared to 769 after 11 days, the mean period, and the mortality was less in their 4 cases, what they could find. Probably this is because of increased surveillance, probably increased awareness, and frequently doing ammonia could pick up at low levels, which could translate into good outcomes in their own case series. So this is how the study. Anyway, I'm not discussing this slide because we discussed in the previous slide. So the interesting thing, one thing I want to tell, I was telling about ureaplasma ureolyticum. This is one organism which doesn't have cell wall, even mycoplasma hominis. That is the reason we could not be able to culture these organisms that easily with routine blood culture or whatever culture methods we use. So here, if you look at in this figure, circular figure in number 1, where if there is associated acute renal failure, as the urea will be excreted through normally, which can be elevated. Once it is elevated, there is a possibility that post-transplant lung, if you look at in this picture, the blue, the purple colored one are the organisms like something like ureaplasma ureolyticum. When there is increased urea, they actually convert this all urea into ammonia. So this ammonia will be shunted again. It should be actually going towards hepatic route and can actually get detoxified, but liver can get overwhelmed with a lot of ammonia, and it will go to the brain, and it will cause a lot of astrocyte damage and swelling and neuroinflammatory pathways, leading to a lot of excitotoxicity, and then leading to sometimes even severe cerebral edema, and the patient can die. So they proposed one surveillance protocol where generally after lung transplant, they can look at serum ammonia levels until day 7 post transplant, even more than that. And general other than general, what they'll do intraoperative swabs of the lungs. Post operatively, they do a bronchoscopy, and Here, one interesting finding other than regular cultures, mycoplasma, ureaplasma, NAT test, nucleic acid amplification test, to find out whether those organisms are there. Because if you find out, you will be more careful in dealing with these patients, probably institute early the decrease anti-hyperammonemia therapies to get good outcomes. So as I was telling how the pathophysiology happens, if these two figures you look at, the hyperammonemia, how it causes the problems, the pathophysiology and the symptoms, generally it leads to dysregulation. There is a glutamine nitric oxide CGMP pathway where there will be increased glutamate, increased NMDA activation, calcium. These all cause neuroinflammation along with interleukins, which will lead to a lot of astrocyte damage, especially, and blood-brain barrier disruption, leading to a lot of the energy failure, cellular edema, then which will subsequently lead to cerebral edema, seizures, and then probably increased ICP, sometimes herniation. This is so the brain is the one which is very much affected with hyperammonemia. So with this background, what can be the different causes that when we think of non-hepatic hyperammonemia, any patient coming with altered sensorium, unexplained, sometimes we may have to look at these causes. If they are there, probably work up towards sending an ammonia. Something like organ transplant, lung, heart, bone marrow, and drugs like, as I was discussing in my first case of valproic acid, other drugs like halothane, 5-fluorouracil, haloperidol, this we use in ICU sometimes, and salicylates. Urea cycle defects, not very common, especially in newborns and pediatric age groups. This is most common genetic abnormality, but some studies they say they can be subtle defects which can be exacerbated with some predisposing condition. And another interesting I told about ureaplasma and all. And urinary diversion, something like ureterosigmoidostomy, ileal conduit, these patients are also at risk of developing hyperammonemia. Roux-en-Y GB surgery, gastric bypass surgery patients. Nowadays, I think Roux-en-Y is not very much practiced in the gastric banding and sleeve gastrectomy. But yeah, here and there, the cases, these patients also are at risk. Hyperalimentation, TPN, and all these patients are also at risk of developing, which is very common in ICUs we practice. So the question comes to, yeah, as of now, we discussed causes, pathophysiology, and then if you find out what to do, then the probably the management lies in doing renal replacement therapies to effectively eliminate or take out the ammonia from the body. So, but most of the studies say no definitive answers here, but there are some clinical scenarios. Most of the evidence is towards opinion based and personal, primarily experience driven data looks to be scant in this because it is not a very common entity. If you look at the dialytic properties of ammonia, which we have to explore, and probably this is one thing which helps in doing RRT and eliminating the ammonia, it have a diffuse clearance similar to urea, and in vitro clearance is as high as 225 ml per minute, and it's not protein bound, and the clearance is well dependent on blood flow, dialysate flow, and membrane surface area. So altogether, these properties make us to do hemodialysis for highest clearance initially, but later once we get good clearance, probably switching over to continuous venous hemofiltration or hemodialysis are effective for maintenance. So when we generally think of the dialysis in cases of hyperammonemia, maybe even liver disease and kidney disease, because these patients invariably may be landing up in these diseases. So the clear-cut thing is liver disease with a cirrhosis with maybe a decompensated thing, the gradual ammonia elevation will be there. Here, the RRT may not be helpful. So clear-cut, no. Acute liver failure, yes. Hyperammonemia, we do see sometimes more than 200, 300, it is helpful. Acute liver failure and AKI, definitely likely easy. So this is all hepatic causes. So hyperammonemia and AKI, definitely, because renal is the one which is the root, the ammonia has to be excreted. Here, definitely it is yes, because there is an associated AKI. CKD, hyperammonemia, and there is altered mental status. So most of the times they tried medical therapies in these patients, something like rifaximin, lactulose, sodium benzoate, and all. but otherwise not much of a role of probably the RRT as such, otherwise if the progression of CKD happens. So absence of liver disease, hyperammonemia, and no AKI. So here the evidence is scant. As I was telling, it's a more of personal. Probably if the patient is very bad, we'll go for it. So generally, one study they said their approach to be towards it is they do hemodialysis, and most of other literature I checked, even in up to date and all, it shows that initially do a hemodialysis with good blood flow of around 400 to 450 ml per minute and dialysis flow of as 800 ml per minute. Then probably once the clearance is satisfactory, you will be transitioning these patients to CVVH and CVH as I was telling it. So reduce the blood flow to 250 and dialysate flow 500. So most of the times the important clinching thing is to look at the hemodynamic stability. These patients only having hyperammonemia without much other background things, they will be most of the times hemodynamically stable. So the end point is generally the thing you look at is clinical status. What's happening to the sensorium, whether it's improving, the patient sensorium getting better. That is what we generally look at. So when to stop? This is again a question where probably it is a bit intriguing because there are limitations for this RRT because there will be a rebound. You remove the ammonia, but the underlying cause of ammonia production, if you don't treat, there will be rebound effect and the ammonia will comes back to the circulation and you have to continue the RRT until you achieve and underlying problem is solved. And another interesting thing is IC pressure. As we generally look at the cases like the hyponatremia, where suppose you don't want to increase it very much, not like that. What I want to say is dialysis disequilibrium. So where you look at a urea of 300, you don't want to decrease it suddenly because it can lead to cerebral edema. Here the same thing, suppose if there is a ammonia of around 400, if you decrease, whether what happens on IC pressure, whether it can be a paradoxically worsening. So that is what we have to, I think most of the studies did not look at it. And the hemodynamic instability with a lot of blood flow and all. And most of the times, what to do? Bridge to where the patient improves, not improve, whether to do anything other than RRT. This is also a big question. Most of the liver failure cases, of course, the bridge to transplantation can happen. But other than that, non-hepatic causes, it's a bit difficult. So as I was telling, the equilibrium and IC pressure both are one in the same. The summary comes to the hemodialysis, the preferred method of RRT when a rapid reduction of ammonia level is desired, and then switch over to maintain lower ammonia levels to CVH and CVHD. And some studies say neonates, because they have a low volume of distribution, peritoneal dialysis can be of help. So the best clearance is achieved via high blood flow rates, high dialysate flow rates, large surface area dialysis, but keeping in mind about hemodynamic stability. So with this, I think I will end my session. Thank you, sir. Back to you, sir, Mishra, sir.
Yeah, thank you very much, Dr. Kaladar. I think it was an extensive presentation with some few very interesting and maybe very rare conditions where we see non-hepatic hyperammonemia. So, before taking our expert panelist onto board, just I want to touch upon few of the things what we need to understand. One, see what we need to understand when it comes to ammonia. Some basics before going to the different questions and all to our expert panelists. The ammonia is formed, the two substrates mainly is one is protein and second is glutamate. These are the two substrates which will produce ammonia, and that ammonia is usually produced in the intestines by our different gut bacteria, and that once go to the liver will detoxify in the urea cycle to produce urea. Those urea will be excreted in kidney. One more important maybe organ are the muscles, which take up a lot of ammonia and they convert into glutamate. Even when the ammonia is high, the ammonia can be used in brain and will be stored as glutamine, which itself can cause astrocyte swelling and all signs of increased ICU. So this is the basic thing. And whenever there is a issue in any of these four or five things, we can have hyperammonia. And if liver dysfunction is there, which is more common or maybe most known thing when it comes to hyperammonemia, but other things maybe some infection where the production rate is high or protein load is high. In all those conditions also, we can see hyperammonemia. So to start, I will request Dharmesh Kapoor sir to answer this because he is having the vast experience when it comes to ammonia because he is the hepatologist here and working since like maybe 3 decades or 4 decades. I may not be clearly know how many years he's practicing. Sir, when we should consider like non-hepatic hyperammonemia in a patient with the liver dysfunction is not there, when we should consider and when we should think of sending a serum ammonia in a patient, sir?
I think that's a wonderful question and probably the one to which I don't know the answer with certainty. I think Dr. Kaladhar did a commendable job. The cases that he presented were absolutely fab and they bring out a lot of points for discussion, but at the same time, they also raise a lot of things that one might not, just see superficially. So, first and foremost, coming to the question that you asked, when should you suspect somebody to be having non hepatic hyperammonemia in the ICU? Anybody who's got an altered cognition for which there isn't an obvious cause. And I'll come to what is obvious and what is not. That might be a situation in which you might want to, send off a serum ammonia sample. Now, the story with ammonia is that the blood sample means different things to different people. There is a way of drawing ammonia when you sample a particular patient, and I think the attendees to this webinar should all be absolutely, on the spot when it comes to how to take a sample for ammonia. So it has to be a free flow of blood. Mostly the arterial ammonia samples are preferred, a because you know that, and right, like you just mentioned, that muscle is a sink for ammonia. So if you check arterial ammonia vis-a-vis venous ammonia, you'll always find the arterial ammonia to be higher, because if you have good muscle mass, then there will be a kind of a sink effect for the ammonia. However, it might not be very useful in our category of patients, especially chronic liver disease patients, because many of them are sarcopenic, and therefore you do not. So when somebody asks us on the round or fellows in training that, sir, if there is no art line, do you want us to draw an arterial blood just for the ammonia? The answer in a cirrhotic patient whose end stage is that no, maybe the venous also would be equally good, but it should be free flowing. It has to be collected and then placed on ice, and then it has to be processed ideally within 30 minutes. The best studies that have happened in the space of ammonia assays are when ammonia has been assayed in 10 minutes. So much so that some years ago there was a kind of a dipsticks which was mooted for testing the plasma ammonia level, but somehow it did not catch people's fancy, and still we are doing it the conventional way of checking it in the blood. So, long story short, free flowing. Do not use tourniquet. Do not clench, unclench your fist. Arterial is better than venous in somebody who has got normal muscular build, and it has to be placed on ice and sent to the lab very quickly. So, if you have done all of these things and still you get an elevated ammonia level, then the ICU doctor is going to send a consult to you to say that this patient is having hyperammonemia. What do you do about it? The etiologies which Dr. Kaladhar mentioned, especially the urea cycle defects getting unmasked in a sick patient, they are good case reports on that, but I don't think that in day-to-day practice this is something that you would want to do. In any case, if you have to do an exome sequencing for detecting one of these urea cycle defects, there is going to be a good turnaround time, and by that time either your patient would have recovered or he might have succumbed. So it's a good thing to keep at the back of your mind in someone who's having these episodes on a recurrent basis. So as a first step, I would not say that you should think of a UCD or a urea cycle defect. Now oftentimes they will say, now does any one of us know? All of us are experts. Does any one of us know what is the normal ammonia level? I don't think we know the answer to that question. I think it would be something less than 10 micromoles per liter. But if you see the published literature, that tells you any value up to 30 is normal. And then they further classified it into a moderate hyperammonemia or a severe hyperammonemia. So any value which is more than 35 to up to 100 micmoles, we call it moderate, and anything more than 100, we call it severe. Now, where this arbitrary transition come from? So why more than 100? Why not 75? Why not 80? So there is an answer to that, but that answer comes from the liver literature. Third is that when we say that somebody has got non-hepatic origin, now non-hepatic, and this is the most important part of my answer, means different things to different people. So you heard in Dr. Kaladhar's description of Roux-en-Y gastric bypass that when these patients were assessed for liver fibrosis, and mind you, liver fibrosis is not the be all and end all of liver dysfunction. It's just a kind of a static marker. They did see that some of these patients had some degree of liver fibrosis, which was hitherto not known. Now, what is this category of patients that you are dealing with? So, Roux-en-Y gastric bypass is done for whom? It is done generally for people who are morbidly obese or who have got lower grades of obesity with any other metabolic risk factor. I would be willing to bet anything that these people do not have normal livers, even though they might not be frankly cirrhotic. The most important thing that we as ICU doctors and not necessarily hepatologists should always remember is that any degree of hemodynamic compromise will have a bearing on what happens to the liver blood flow. This is such a hugely interesting topic that you could just go on, and probably at the end of this discussion you would think that there is probably nothing which is non-hepatic hyperammonemia. So everything that is there in hyperammonemia has a reflection in the liver somehow. So what Dr. Kaladhar did not mention in the extensive list of the differential diagnoses is ischemia and hypoxia. So these two are very, very common causes in which the liver blood flow would be altered. Now, we as hepatologists, even though we've been studying the liver for decades, we do not know what happens to the hepatic blood flow when somebody develops hypotension. We only know that there is a arterial spill, isn't it? So whenever you develop hypotension, what do we know? We say that whenever you have got a state in which you have a hemodynamic compromise, the body will preferentially try to send the blood to the vital organs, and there will be a splanchnic spill, right? So this splanchnic spill obviously means that you are drawing the blood away from the podomesenteric circulation. So why would that not be one of the inducers of this syndrome of hyperammonemia? The other important thing that we must remember in the ICU setting is, again, which Dr. Kaladhar's list did not mention, is the relationship of caloric deprivation and hyperammonemia. So when do you start breaking down your muscle? When do you start using your own tissues to be a substrate for providing substrate to your body? So that is when you are caloric deprived. So oftentimes our patients who are there in the ICU might not being fed adequately, or they might be, truly patients in whom you cannot engage the gut for one reason or the other. So I think there are, and what you mentioned about the specific organisms which break down the which break down the urea. Now, why did the urea not get excreted by the kidneys in the first place? So there is a very interesting discussion that we in our hepatology circles have, which is called inter-organ ammonia metabolism, or crosstalk. So, the kidney is also one of the organs which can produce ammonia, and that particular ratio of producing ammonia and excreting ammonia gets reversed whenever you have got any degree of liver dysfunction. So there are so many nuances to this very intriguing question as to something is truly non-hepatic. I'm sure there is, but I cannot tell you very dogmatically that everything that you deal with is non-hepatic. So I think if your liver is good, if your liver has got good blood supply, if your hemodynamics are stable, if your body is not utilizing abnormal substrates, then there is no reason your body should not be able to handle ammonia and not have this syndrome produced at all.
Oh, nicely and interestingly told, sir. I think there is a question in the chat box. I just want to emphasize what sir told. See, the blood sample, when we are sending for ammonia, it has to be from a site with a free flow of blood. So, arterial sample is always better suited when it comes to ammonia than your venous samples. And better to be, the test should be done as early as possible. The time frame should be less than 30 minutes. If it is less than 10 minutes, it's even better. And they have suggested to send it with good anticoagulation and proper cold chain maintenance need to be done to have a proper ammonia level to prevent the pre-analytic error when it comes to ammonia. I think Sir told one more very interesting thing that I didn't read actually. I've gone through few of the articles. I think one of the best thing what Sir told is in ICU where we have so much of hemodynamic instability, hypoxia and ischemia to the liver, maybe one of the important thing what we most of the time ignore till the our our enzymes and all are not sky high. Sir, small one more question, maybe the next question. What do you believe might be the prevalence, sir, of non-hepatic hyperammonemia compared to our hepatic hyperammonemia in ICUs? Is it like underdiagnosed most of the time, or like
So I think if you have a patient who's got established liver history, either by way of acute liver failure or who's a cirrhotic or who has some injury to the liver, which is obvious, by way of his clinical presentation, lab data, and imaging, then you would put that label as a hepatic hyperammonemia. But in all other situations, when you do not have this kind of a background history, you would say that it is non-hepatic hyperammonemia. But the conundrum is that even if you've diagnosed it, when is it that you would want really to act upon it? So I think again the jury is out on this question. So obviously, Dr. Kaladhar sir mentioned one patient who had got an ammonia level of say 480, and you would be led into believing that this is extraordinarily high and something that can indeed produce cerebral edema, and then therefore this patient can have neurologic sequelae. So ammonia is brain toxic. There is no doubt about this statement. Now, how ammonia produces neurotoxicity again is it's a very interesting topic, and there are various shades to it, especially in the context of liver disease, because I must tell your audience that in patients with acute liver failure, I know I'm slightly digressing from the main talk. In patients with acute liver failure, ammonia has got a huge prognostic value. But in patients with chronic liver disease, even we as hepatologists debate whether ammonia is actually a test that you should be sending or not in a patient who's got abnormal cognition. The only thing is, if someone has got an abnormal cognition and has got a serum ammonia level which is less than say 30 or 40, and for all practical purposes we take 40, then you should think of an alternate cause. So obviously, you know that acute liver failure is a very, very uncommon condition compared to chronic liver disease. And in chronic liver disease, to get hepatic encephalopathy is fairly common. Almost a third of our admissions would have some degree of cognitive impairment. And if you start sending ammonia for each and every patient and then trying to correlate, so oftentimes you will find that the ammonia levels are not high and it is still hepatic. And even worse is when your patient's cognition has improved but the ammonia stays high. So, what do you think brought this turnaround? So, that is why ammonia is such a difficult parameter to act upon. And therefore, some of us believe, and there are some very interesting studies published in liver literature where they have even checked by microdialytic catheter the ammonia in the CSF. So that is called the ammonia tension. We call it just like you have the pH, PCO2, PO2, you have got the PNH3. And the PNH3 has got a much better correlation with your cognitive impairment than your plasma ammonia levels have, whether it is arterial or venous. The other test which is worth reporting and which has got a far greater correlation with your abnormal cognition is CSF glutamine. So again, we must understand that when we are checking the plasma ammonia, when somebody has got a state of sustained hyperammonemia, then the way the brain will take up this ammonia from the blood also changes. The surface area across which the ammonia is taken up by the brain becomes it becomes much larger than what it was at the baseline before this phase of sustained hyperammonemia. So that is why you might see someone who's having normal plasma ammonia levels but still has cognitive impairment, and you would be scratching your heads as to why that is happening. So that is why in the liver literature also, ammonia other than acute liver failure for all practical purposes is non-actionable, but treat everything else. So treat the if somebody has got constipation, you treat that. Sir already mentioned about lactulose. You are using increasingly the non-absorbable antimicrobials like rifaximin, build on the nutrition, and then obviously in acute liver failure only you will come to a stage when you would want to use RRT. So other than acute liver failure, for chronic liver disease patients, generally we would not resort to any kind of an RRT just to treat hyperammonemia. And infection is a very common cause. So the inflammatory pathways, and he mentioned briefly in that pathophysiologic slide about IL-1, IL-6, TNF alpha, so on and so forth, which are again the cytokines which actually lead to a higher permeation of the ammonia to the across the blood-brain barrier.
Thank you very much, sir. Not only like non-hepatic, you are giving a clear picture in hepatic causes of hyperammonemia also. Actually, I was going through one of the studies where it has been mentioned what you told, like a single ammonia value cannot tell us like is it really correlate with the degree of even our hepatic encephalopathy. They have seen that in grade 4 hepatic encephalopathy, when the patient is having coma also, they have normal ammonia. So
Absolutely.
I think you have narrated it nicely. Actually, the doubts what I had is clear now. Sir, is there any like role of repeating ammonia if let's say patient is still altered sensorium, maybe initial ammonia is high or low? Is there any role or repeating? If at all is there, then how frequently we should repeat? So this is one of the questions in the chat box.
Right. So, like I said, and I didn't talk about that much because that is in itself a huge topic. What is the role of ammonia in acute liver failure? In acute liver failure, yes, because it decides what you want to do to a given patient. So, if your patient has got even a grade 3 hepatic encephalopathy, but if this patient is having hyperammonemia, and in acute liver failure, we define it as a value of more than 124 micromoles per liter. This was a very famous landmark Scandinavian study where they showed that this value in arterial ammonia, which was more than 124 micromoles, and this led to an increased ICP as well as cerebral herniation. So this was a study which was published more than 2 decades ago, and it's still worth its weight in gold. And therefore, that by itself is an indication for an RRT. So just hyperammonemia, nothing else. You don't have any other marker in a given patient in acute liver failure, and therefore you would also want to assess as to what is happening to this hyperammonemia as you treat this patient. So those patients in whom the hyperammonemia is protracted and it does not respond to standard of care, then again you have to be very careful in suggesting transplant to these patients, because we people do not put ICP monitors, we do people do not put bolts. So we have got only non-invasive tools like transcranial Doppler, optic nerve sheath diameter, and clinical ways of knowing whether somebody would be irreversibly brain damaged. So when you have got ALF for whom you are suggesting transplant, what is the biggest fear that an ICU doctor or a hepatologist or a transplant surgeon has? It is not that you will be able to do the transplant successfully or not. These people are very simple to transplant because they don't have portal hypertension. The transplant happens very quickly. Your biggest fear is whether this patient will wake up after the transplant or not. So that is the most important fear in this category of patients. So therefore, if you put somebody on RRT and their ammonia is not dropping, you have to take a few steps back, and you should not rush into transplant. See if something else is going on which is contributing to this indolent hyperammonemia. And of course, sir very elegantly said that CVVH, which is what we use most commonly in this category of patients, it is dependent on the blood flow, it is dependent on the effluent rate, and therefore you might want to increase both of them to have a better clearance. Obviously, for us to use intermittent RRT is not a very good option because many of our patients are hemodynamically unstable. So whenever we have to resort to a renal replacement therapy to treat hyperammonemia, almost always it will be CVVH or CVVH-DF. Probably the first one more often even than the second one. So that is the answer to the question as to how frequent. So if someone is on a treatment, you would use it. The other things which is more in the domain of pediatric hepatology is people, young children who are diagnosed with urea cycle defect, or who are diagnosed with things like organic acidemias, or who have got fatty oxidation defects. So those are the patients where you are using the oral agents mostly, but in the initial stages you are subjecting them to RRT. So there is a sense in doing serial ammonia levels, so that you know that you can hook them off RRT and then they can only be on the ammonia scavengers.
Thank you very much, sir. I think we have Dr. Mahesh, is our consultant nephrologist from Yashoda Hitec City. He can give us some more idea when it comes to hyperammonemia. Mostly we'll come back to maybe non-hepatic hyperammonemia. In these cases, like if let's see the common results, whatever we do for hyperammonemia, if not improving the general condition, when we should think of dialysis, already sir told briefly everything. If you want to add something, when we should think of dialysis and what will be the common mode and how to continue.
Yes, sir. I think Dr. Kaladhar sir has explained it in a better way in the initial part of our discussion. Let me tell you an example of a hyperammonia case. This was my first presentation on CRRT San Diego. It was a 40-year-old female renal transplant recipient. She was discharged on post-operative day 5 with normal renal function. And post-operative day 7, she came to the hospital for a regular checkup and she was found to have severe abdominal pain. And on post-operative day 8, she went into mild altered sensorium. And on post-operative day 9, she was completely knocked off. But her hemodynamics was borderline, her renal functions was normal, and her liver function test was normal. And because we have worked up for many of the patients in a post-transplant period for altered sensorium, we always keep our threshold low to check the blood ammonia levels. So apparently in this patient also, I have checked blood ammonia level, and surprisingly, can't just imagine her blood ammonia level was 1200 millimoles per liter, which was sky high. And because when we know about the molecular properties of the ammonia, its molecular weight is very low. It will be in around 17 daltons, which is very, very lower than urea. And at the same time, it is just something like a electrolyte, like sodium or potassium or any other electrolyte. So when we think that the ammonia level has been elevated in these patients very rapidly, we take into consideration like the similar kind of hyponatremia. When a patient develops acute severe hyponatremia, we will try to increase the levels rapidly, but we don't try to increase the level of sodium rapidly in a patient with chronic hyponatremia. So taking this into consideration, we have started this patient on intermittent hemodialysis. And we kept a very low threshold to check the urine for urea plasma and mycoplasma levels. And we are a bit aware of the situation that these levels, these microorganisms are not routinely detected in the culture. So we have sent it for nucleic acid testing. It was positive for urea plasma urolytica. But even before sending this for urine for NAT, we have started the patient on doxycycline. So after first session of hemodiafiltration, I did not do hemodialysis. I did hemodiafiltration for 8 hours. From 1100, it came to 600. And from 600, it came to 400 and 400 to 200. And by the time it reached 200, in the 72 hours, the patient was on doxycycline. So we have treated the patient successfully in the sense we have addressed the issue because immediately in the post-transplant period, patient will be receiving significant amount of the steroids that can increase the urea level. And on the top of it, if the patient develops the urea plasma urolytic infection, which produces significant levels of urease that can convert the urea into ammonia, this will make the patient little bit imbalanced as far as the ammonia is concerned. So I would suggest if the levels are very high rapidly, let's go with intermittent hemodialysis. or hemodiafiltration and address the issue, primary issue, in the sense check the list of the conditions or drugs what Dr. Kaladar has explained. If any of that is present, treat that first in parallel with renal replacement. And I think by combination of renal replacement therapy and addressing the root cause of hyperammonia, we can achieve our treatment goals easily. So go ahead with intermittent hemodialysis. And if the root cause is not treated, or we could suppose for any reason, if we are unable to treat the root cause and to decrease the levels slowly, we may go with CVVH or CVVHDF, whatever is convenient for us.
Thank you, Mahesh. I think you nicely told with the case what you have treated earlier. I think clarified most of the things. But in acute liver failure, when we believe there is a significant raised ICP, not in cases where we don't believe there is a liver failure, but still in those
Yes, sir.
cases, because of raised
Yes, sir.
ICP, we prefer CVB
Yes,
SDF.
it's just like sodium disorder. We cannot treat any metabolic abnormality that is precipitating cerebral edema rapidly if it is developing slowly. In otherwise, if it is going very rapidly, don't treat it slowly. My patient who came to OPD walking in, and in just 24 hours he developed altered behavior, and within 72 hours it went up very rapidly. So my idea of intention to treat it is very rapidly. But I think I am not sure whether we do it similarly in acute liver injury or chronic liver injury, where the cerebral edema in relation to ammonia happens over a period of time. So we should treat it very slowly by continuous renal replacement therapy.
I think it was very clear. Thank you, Dr. Mahesh. Dharmesh sir, this we have discussed few of the etiology where we see non-hepatic hyperammonemia. Can you just give us some more light on other causes or etiologies? Is it like idiopathic is more common, or are we underdiagnosing?
I think the list that he mentioned was fairly a comprehensive one. And there are some procedures which we no longer do, which is like the diversion that he mentioned. So those procedures are no longer done. And I'm sure the patients with bariatric surgery, this is again a incompletely studied topic, because we know that even in yesteryears there were patients who used to have abnormal cognition after the bariatric surgery, when the current bariatric surgeries were not in vogue. But you won't see too much of published literature from that era regarding hyperammonemia to be probably a cause that might have led to this abnormal cognition. So drugs, there is a huge list. He mentioned about valproate. I think many of the anti-epileptics can produce that. And then the nutrition. So I think nutrition is one factor that we underestimate hugely, and that is something to bear in mind. The only thing that which is very interesting pathophysiologically, and which your attendees to this webinar might be intrigued by, is that we keep talking about the ammonia being mopped up, say, by the skeletal muscle. And briefly, Dr. Kaladar also alluded to that, right? So you have got someone who's got good skeletal muscle mass, and the ammonia went into the muscle, got converted to glutamate, and then that formed glutamine. So what happens to that glutamine?
Again, it will get converted to ammonia.
Yeah, so there is the trick. So you mopped up.
At this point, I would like to just come in the middle of conversation. So as Dr. Kaladar said and Dr. Dharmesh said, when it comes to kidney and ammonia, so the first point that what we have to remember is kidney will come into picture, and in case of ammonia whenever there is only acidosis. So when our body is having any acidosis, the kidney has to remove that acid in the form of titratable acids. Initially, suppose if I develop acidosis from today evening, my kidney cannot excrete that acid levels in the form of ammonia. It usually takes 4 to 7 days for the conversion of this glutamate into ammonia, and that ammonia to get excreted in from the kidney usually takes 4 to 7 days. In the initial part of the acidemia, the kidney will excrete other titratable acid like phosphoric acid, creatinine, or uric acid. So when the patient has any kidney problem, these acid levels will not be converted into the ammonia, and the patient will succumb with, I mean, the acid levels may not be converted into ammonia, and patient will succumb with severe metabolic acidosis. The same thing happens in many of the critically ill patients. As Sir said, Dharmesh sir said, even a patient is having a shock, the blood will be diverted from the hepatic circulation, with there will be some splenic steal. Similarly, what we do routinely, suppose if the patient comes to our unit, if the patient has a septic shock and if the patient has AK and metabolic acidosis, we generally routinely what we do is we put the patient on any modality of renal replacement therapy. When we put the patient on any modality of renal replacement therapy, like any other electrolyte, sodium, urea, creatinine, this ammonia also will go off. So we cannot exactly say what is the amount of ammonia where we have to start the renal replacement therapy. Because when we do renal replacement therapy, that itself means that the kidney is unable to excrete this the amount of ammonia which is being present in the patient's circulation. So what I can suggest is the mainly the clinical history of the patient, and at the same time the symptoms of the patients also has to be taken into consideration when you want to offer any renal replacement therapy for hyperammonemia.
So, Dr. Mahesh, what is your thinking about the acid-base status and ammonia production as well as toxicity? So, what do you feel happens? Is it to do with acidemia or is it to do with alkalemia?
Sir, it is do with both, sir. See, when we see about, suppose if the patient has a chronic metabolic acidosis of any etiology, but if the patient has a functioning kidneys, the kidneys will definitely excrete the amount of ammonia which is being which it has to be excreted as a titratable acid. Suppose if the patient has a hypokalemia, for example, this hypokalemia will always precipitate metabolic alkalosis. When there is a significant metabolic alkalosis for a patient, and on the top of it, if the patient has a liver injury, the patient will be producing more and more of ammonia in the body, but the kidney will not excrete that ammonia because the kidneys will always sense the ammonia whenever there is an acidity. But if there is significant alkalosis, kidneys will not detect or it doesn't do its job to eliminate this ammonia because kidneys is not the ammonia which is being excreted from the kidneys is not produced in the bloodstream. It is the glutamate which is going into the proximal tubular cells. It is converted into ammonia, and kidney is excreting ammonia, which is the excess acid which is present in the body. When there is an alkalosis, kidneys will never detect that alkalosis, and that's why most of the patients with chronic hypokalemia or hypokalemia in the background of liver dysfunction, the ammonia will not be secreted from the kidneys. So at that point of time, I think it will be better to offer renal replacement therapy to overcome that hyperammonemia level.
Right. So that is more in the context of chronic disease rather than
Yes,
acute. So I
yes, sir.
think the kidneys, they become the net producers of ammonia when you have patients with chronic liver disease. But
Yes,
of
sir.
course, that is for another day. So coming back to what I was saying, that you had
Sorry to
gluten.
interrupt, sir. Very
Yeah.
sorry to interrupt. I think we are like maybe 5-10 minutes left. We are without
Well, I think
knowledge. We
let's
are
take questions from
already
the
spent
chat
one
box
hour,
then.
sir.
Yeah,
We
let's
are
take
already
questions
spent
from the
one
chat.
hour. Just 2-3 things to add, sir. Whatever we have discussed, I think
Sir,
validly you have asked.
I'm sorry. I would like to take up the question I was asking asked by Dharmesh Kapoor, sir. We can always answer it later, but I want to listen his question completely. He was
But
asking.
actually, just to add, Dr. Mahesh, nothing actually. Sir was telling the same thing. Whenever there is a hyperammonemia, it has been suggested that metabolic alkalosis and hypokalemia is worse, where ammonia excretion or ammonium ion, which is the acidic form of ammonia, doesn't get excreted, so ammonia levels will be higher.
Yeah.
Whenever there is a metabolic acidosis or hyperkalemia, these are the conditions where we can excrete ammonia in the form of ammonium ion
Yes.
in a better way. So that
Yes.
is what was Sir was, I think, stressing. If I am not wrong, is it correct, sir? Dharmesh
Yeah,
sir?
yeah, that's what. So you do
Yeah.
not want an alkaline pH in someone
Metabolic
with disease.
alkalosis
Yes.
is
Yes.
worse.
Sure, sir.
And
And
regarding
Exactly.
actually
there is another biochemical explanation for that also, which we'll talk about some other time.
just to add for the audience few things regarding the like etiology, it has been like described as increased production, decreased excretion, or multifactorial. the conditions where the protein load will increase. Let's see any hypercatabolic state or states like upper GI bleed where the protein load will be high or patient is on steroids. All those cases where protein load is high, that can eventually go to hyperammonia if there is some kidney dysfunction or maybe load is very high. Apart from that, different infections, I think Dr. Kaladhar has already told, like ureaplasma, urealyticum, mycoplasma hominis. Even there is other form of urinary tract. They are mostly urinary tract infection, which has been like related to non-hepatic hyperammonemia. Even E. coli, Klebsiella, Pseudomonas, and Proteus also with urinary tract infection, they have been implicated to have non-hepatic hyperammonemia. The conditions where clearance will be low. The most common condition may be urea disorders, which happens usually in the children's, not in the adult, but we say yes, we can see in adult group also. And maybe AKI, one of the important thing, and drugs like Valproic, other chemotherapeutic agents, I think sir has already told, and surgery related things we have discussed. Just for this is for the audience so that they will have some complete idea. Sir, few quick questions, Sir Dharmesh sir. So how we should treat these cases of non-hepatic hyperammonemia? Is it different than a hepatic, or is it more or less same, sir?
So I think we've answered this question along the way. So one is the severity and whether it produces any neurocognitive dysfunction. So those will be the two important things. Attack the cause. So if it is only someone who's having, say, an elevated value of, say, 80 micmoles, and you find that this patient has got other things also which could be responsible for a subtle decline in his neurocognition, I would just hold back my horses. I would just want to attack the cause. Only when someone has got a very profound kind of a decline and you think that there are no other competing diagnoses or there is impending cerebral edema, and again we do not know in the non-liver space as to what is that critical threshold. Of course, here we are talking about one patient with a value of 450, another patient with a value of 1200. What about modest values? What about somebody with 100 or 150? So one would have to be very nuanced in one's approach, because when you are starting these patients on RRT, you must also be able to say, and this is what Dr. Kaladhar mentioned in his last slide, when to stop. There has to be a time to stop. So unless you have found the cause, you will not be able to stop. So you must be able to find the cause and address that too. Like in Dr. Mahesh's patient, they found that this patient had a urinary tract infection with a putative bug which is responsible for hyperammonemia. So I think those would be the deciding factors for me. So that is why I very sparingly get this test done in the ICU. I'm actually more at a loss when they turn around and but mind you, most of the referrals are for very modest values. They are not for values which run into good double digits.
Thank you very much, sir. I think very lucidly you are answering everything. I think all of us is getting cleared about a lot of our doubts throughout the way of
I think
this
there is
last
some
1 hour.
gentleman who says that we have not addressed the questions
Address
in
the
the chat
questions.
box. Yeah. So let's
So there
just
are two things, sir. In the one question is in ALF, should RRT be continued longer or prevent rebound? And second thing he has asked again, like high volume plasma exchange. These are in ALF what he has asked.
right.
Basically, it is
So
diverted
for,
to from
yeah,
RRT.
so for ALF, like I mentioned, that you have to continue till such time either the patient's encephalopathy gets better, or if it is not getting better and other markers. And in this context, the INR remains the key player, which tells you that yes, this patient's liver is not getting back on track. Then you have to have it as a bridge to transplant. At times, you will also be using an intraoperative CRRT in these patients, because huge amount of changes, hemodynamic changes occur in brain circulation, especially in the when you are removing the liver, which is the dissection phase, and then more importantly when the liver gets reperfused. So these are the times when you can have rebounds in intracranial pressure. So at times we would want the RRT to continue even in the operating room while the transplant is happening. And the second question was,
High volume plasma exchange, sir,
right.
in ALF.
So high volume plasma exchange is something that most of us don't do. So there is only one publication from Finn Larson's group, which was in acute liver failure patients, where high volume plasma exchange was supposedly better. So high volume plasma exchange, for those of us who don't know, it's about 8 to 8.5 liters of plasma, and that's an extraordinarily high volume of plasma. There is a lot of published literature from our country, from north from ILBS and from south from CMC Vellore, where they have used low volume or standard volume plasma exchange, which is about 1.5 to 2. So plasma exchange is also known to help with hyperammonemia, though not to the same extent as the other RRTs would, because we have already addressed this question that it is dependent on the blood flow. So we know that, and most of us are doing it by the centrifugation technique. Not many of us do it the dialytic way, and therefore the blood flows are really modest in that. But it is also in that study they showed that the hyperammonemia was beneficially affected by this, and that also invokes the inflammatory pathways, because the changes that happened after the high volume plasma exchange with respect to the inflammatory pathways were much more profound than they happened with respect to the hemodynamics.
Sir, I think we'll take the last question, sir. Urea cycle disorder, how common it is in adults and role of sodium benzoate?
So, like I said, so you do not suspect a UCD in a patient who's come to you first up and in the one-off presentation. When somebody is having recurrent episodes of these recurrent episodes of hyperammonemia, that is when you start to think of these disorders. And mind you, you have to be very careful with the hyperammonemia bit. So if you look at the urea cycle, it is only in the early steps of hyperammonemia that hyperammonemia would be seen. If you have disorders down the path of the urea cycle, the ammonia levels might not be very high, and those patients will have a different kind of a neurological presentation. But oftentimes these tests have got a long turnaround time, long TAT, and therefore you will not have your values available readily. So that is why in clinical practice, if someone is developing this on a recurrent basis, you should suspect it. But the
Thank you very much.
carnitine thing is very, very interesting. That is again a low hanging fruit. We must remember that carnitine, and Dr. Kaladhar very elegantly showed in that slide. So that is a very important player when it comes to inhibition of the urea cycle, and carnitine is something that we use in our ICU practice very frequently. So, and regarding the benzoates, these are industrial products. Mostly they will be used when the initial stages of hyperammonemia have been taken care of. So glyceryl phenyl butyrate, or you have LOPA L-ornithine phenyl acetate. So phenyl butyrate will get converted into phenyl acetate, and that will bind to the glutamine to produce phenylacetyl glutamine, which will be excreted by the kidney. So you need to have normal renal function to be able to do that. Then LOLA, L-ornithine L-aspartate, and sodium benzoate, which is the oldest molecule which has been used for ammonia scavenging. So these are the molecules that you use in cold category of patients. So these are not molecules for immediate use.
Thank you very much, sir. I think uh, uh, two things, sir. Like interesting questions only. Is it like in ICU, the use of broad spectrum antibiotic and causing the alteration in the microbiota has some role in non-hepatic hyperammonemia? And is there any role of activated charcoal in controlling the ammonia level?
So the answer to both is I don't know. So obviously we all have to practice antimicrobial stewardship, use antimicrobials only when it's absolutely necessary. That goes without saying that any antibiotic that use, even so-called safe antibiotics, could alter the gut flora. And you never know. We know only of a few bugs which can, lead to breakdown of urea. So it's not that our knowledge about this particular subject is very comprehensive and complete. Activated charcoal, to my mind, has not been used just to treat this problem, but maybe I would like to read this up. From the top of my head, I can't remember activated charcoal being one of the agents for use in this, because it's a gas. So it's a gas, it's freely miscible, it will just cross the plasma membrane, and that is why I don't think you would find use for something like an activated charcoal, because it will just permeate through any cell membrane in the body.
Any role of pre and probiotic together, sir, to have a
There have been
proper.
studies in the liver literature with use of VSL3 and all, but I think those studies are flawed. I don't think we can promote the use of pre and probiotics just to treat hyperammonemia.
Thank you very much, sir. I think we are 10-15 minutes like over our time, stipulated time, which was around 1 hour. Before concluding, Kaladhar, any final remarks?
I think very, very well discussion, sir. I think it's glory to see Dharmesh sir and really felt what to say, privileged to be there in this panel speaking. So very happy, sir. I think we can go back again, repeat this webinar, and I think probably it's going to have a lot of views as we see in the comment box. I think it's very good discussion indeed. Somebody mentioned, and Mahesh had thrown a light about his own case in a case presentation, and it's really very good, sir. Thank you. Thank you very much, sir. Yeah, nothing much from
Thank
me.
you.
We'll conclude, sir. Thank you very much, all the attendees. I think we had a healthy attendee, and there was a lot of question which was posted with good discussion throughout. And I should thank Dr. Mahesh. At the last minute, he joined actually because Dr. Rajashekara Chakravarthi, because of his some other work, he could not join. Thank you very much, Dr. Mahesh, joining and giving us good idea about what to do in when it comes to dialysis and hyperammonemia. And that Dr. Dharmesh said, like, your profound knowledge is something beyond imaginable, sir. I only heard you before, but this is first time I'm hearing you in person when it comes to some cases and all. I think all the audiences who are listening now and afterward, they will be greatly benefited. I think I need to go back again and listen to the whole thing again, so that there are so many things what we had doubts also got cleared during this 1 hour period. Thank you very much, sir, and thank you all and to be part of this webinar. Hopefully, we had discussed most of the things when it comes to non-hepatic. Apart from non-hepatic hyperammonemia, we have discussed many things related to hepatic related hyperammonemia. Thank you very much, and I should conclude, sir. Thank you
Thank
all.
you. Good night. Cheers.